Good afternoon, my friends and colleagues from outside India, and welcome to the TCT on behalf of the TCT organization in India. Well, I'm going to speak about rotablation in unusual conditions because usual conditions, I'm sure everybody who does rota knows how to do rota in most of the usual conventional conditions. As you know, that ROTA has now got established over the past 3 decades as one of the modalities in the treatment of coronary artery disease, particularly fibrotic and highly calcific stenotic lesions, which are not dilatable or crossable with balloon, and the results of stenting in such situations are suboptimal. Uh, Now, as you know, the cardinal indications as laid down by the manufacturers of rotablation are calcific stenotic lesions and then ostial stenotic lesions like left vein, RCA, aortic coronary graft, and branch osteostenosis. And these are the labeled contraindications put down by the manufacturers of rotablation. Saphenous vein graft stenotic lesions, thrombus containing lesions, if there's a visible dissection caused by a balloon, and total occlusion where you're unable to cross it with a guide wire or even unable to cross with a balloon. And then highly calcified, very angulated, extremely difficult kind of situations. So what I'm going to show you something different today. These are the unusual conditions where I have been doing ROTA, and out of my 1600 cases over the past about 2.5 decades, these are some of the unusual conditions where I have done ROTA. 4 cases of graft stenosis, both arterial and venous, with a clinical success in all and in-hospital complications there. Second group was calcified infarct-related artery in STEMI, where we use rotablation as the primary modality of treatment. And this was done in 6 cases with a success rate in all. And one patient died due to cardiac shock during a stay in the hospital. Then CTO, which was uncrossable with balloon, after having crossed with a guide wire, the balloon doesn't cross. So in such cases, ROTA is of immense help provided you are able to place a ROTA wire in the channel created by the guide wire. So we have 5 such cases and we were successful in 4. One patient we were not sure about the ROTA wire, so we didn't attempt even. Then we had very long diffuse, the whole of the artery is extremely diffuse and calcified, and 39 such patients where we had a clinical success of 38. One patient died during the hospital stay because of contrast-induced nephropathy. Now let me show you the cases and then I'll summarize a few steps. Now this is a gentleman, 68 years, where he had a cabbage in 2009. Lima to LAD was patent and SVG to RCA was occluded. So only SVG was to OM, and patient had class 3 angina with at times rest angina. LV function was normal, and this was his graft to one of the obtuse marginal branches. So I thought it's not a very difficult task for me to end up with a balloon and then doing a stenting. So we took an Amplas guiding catheter, and you can see here that possibly there is something which is looks to be a little calcified, fibrotic, and all kind of mixture of degenerated vein graft. So we spent almost about half an hour in getting the wire across, and all kind of wires were used from softest to the stiffest wire, but we were unable to negotiate a wire across. Finally, luck favored us, and we were able to get a wire down. But after having crossed the lesion with a wire, it was not possible to get anything down. Even a 1 millimeter balloon, then guide zilla, everything would fall down. But we were lucky not to miss the graft from the wire, and the wire continued to be across the stenosis. And you can see here that even a 1 millimeter balloon is not crossing. So what we did was that we then decided to do a ROTA, which was our first case of graft stenosis. And by this time, the literature was very scanty. We were a little scared. So then we took a ROTA wire, and with a lot of difficulty, again, we were able to get a ROTA wire across this stenotic lesion, and then picked up a 1.25 millimeter burr and did a ROTA, which was without any problems. And then we put balloons This is a post-rota balloon. And then we put two long stents, both 32 millimeters, and then cover the entire length of this graft. And this is the final result without any slow flow and respectable result. So when I screened the literature, I found that there were one study where they had treated a saphenous vein graft with rotablation, 14 patients, 17 lesions, and most of it were either distal anastomotic site or ostial aortic sites. The body of the saphenous vein graft was only one with a procedural success rate of 100. And another study where there was a long-term follow-up, which was is osteostenosis treated with a rotablation in the saphenous vein graft to LED, and this was a long-term. So there are very limited literature on this, and one can conclude by saying that rotablation is possible in such cases, but step-bar approach should be avoided because of slow flow or no reflow. Degenerated vein graft should be avoided, and the clinical restenosis rate, whichever is reported, is very low. We come to a second group of patients where we did ROTA as a primary modality of treatment during acute phase of STEMI. And as you know, that calcific stenotic lesions are found in approximately 8% of patients with STEMI, and balloon dilatation with relief of stenosis is not possible in majority of these cases. So, ROTA is generally contraindicated in such cases because of presence of thrombus, ruptured plaque, and high risk of slow flow. I'm going to show you, we have six cases by now, and this is a case which came with extensive interval MI with RBB. Patient was quite sick. So he had earlier undergone a dual chamber pacemaker some 6, 7 years ago. So this was angiogram. You can see here that right is totally gone, highly calcified. LED is totally occluded right from its ostium. Circumflex is co-dominant vessel, but reasonably well preserved. And LED is highly calcified. So we were able to get a wire across the conventional PTC wire, did a lot of thrombosuction, and then we realized that it's a highly calcified vessel and the flow is unlikely to be restored. So we did serial balloon dilatations, and you can see that post balloon the result is not good, only TIMI 2 flow. So at this point, we thought of doing a ROTA. We placed the ROTA wire uh, in the vessel, the lumen being created by the previous balloon dilatation. So having placed a ROTA wire, ROTA floppy wire, we did a ROTA ablation using a 1.25 millimeter balloon. And then after this, we did balloon dilatation using 3 millimeters balloons. And then you can see here that this is a post balloon result, and now the flow looks much better. It is still TIMI 2 plus, not TIMI 3. But we found something in the you can see here that in the carina more towards the circumflex, there is some haziness. So we never wanted to lose the circumflex. So we thought we should stent even the left main in the circumflex. So we put a third stent and from left main to circumflex and wanted to preserve everything over there. And then this is the deployment of desks in the proximal LED. Then just in the left main to circumflex using a reverse T stenting. And this is kissing balloon inflation. And finally pot. And this is the final result. You can see here that you can now possibly see more or less a TIMI 3 flow, which is respectable, and the patient walked out of the hospital. So, screening the literature found that there is again a very scanty literature, and one study which has taken 47 out of 150 patients of acute MI were treated with rotablation. But mind you, there was a time delay between the performance of rotablation and the diagnosis of myocardial infarction. And the 30-day mortality in this series was 6.5%. Maize rate was 15.6%. Now, then the third group is CTO, which is uncrossable with balloon. Now, this is one such example. It's a highly calcified vessel with a retrogradely filling from the left coronary system, a CTO which has been on for the last about 3 or 4 years. Patient was quite symptomatic, class 3, other vessels were normal. So, we were able to get our wire Concast Pro across this long length of stenosis. But even the smallest balloon, 1 millimeter, was unable to cross this CTO. So in the channel created by this wire, we then very slowly advanced the ROTA wire and confirmed that we were in the true lumen. And then we did a ROTA ablation. Uh, and after ROTA ablation, you can see here, after deploying 3 long stents, the final result was excellent. And lastly, a highly calcific bifurcation stenosis, which is in a diffusely diseased calcified coronary artery. This is a gentleman who had a carcinoma of the glottis and was operated with tracheostomy on. He was on chemotherapy. He presented with class 4 angina and acute left ventricular failure. Ejection fraction was 30%. So he was initially treated medically, and then after he was stabilized, we showed it to surgeons who refused to operate upon him because patient was on chemotherapy, and this was his coronary angiographic status. You can see here that there is a highly calcified left main distal stenosis, diffusely diseased, calcified, tortuous, angulated. Everything is there in this left anterior descending coronary artery, except that the distal part of the LAD is reasonably well preserved. So, and similarly, circumflex, obtuse marginal, they are all calcified, diffusely diseased. So we thought that there is no other option except to treat him by ROTA ablation and deploying multiple stents. So his syntax score was 39. So we first use a 1.25 millimeter burr after having placed a ROTA floppy wire, and then stepped up with a 1.5 millimeter burr, and then started deploying stents. Firstly, a distal LED. We deployed a long Promus Premier stent, 38 millimeter long, and then distally we deployed one stent in the LCX OM also, and then decided to do a left main using the mini crush. So you can see here there are 2 stents, one in the LED proximal part, osteoproximal part, and the other one in the proximal circumflex. Using a mini crush, we deployed this left main distal bifurcation stenosis, and this is the final kissing balloon inflation, and this is the final result. But you can see here that there are 2 areas of dissection. One is at the distal edge of the LED stent, and the other is the distal edge of the obtuse marginal stent. So we again treated both these. In one, we deployed a short stent going into the circumflex and deployed it distal to the first stent in the dissected area on the obtuse marginal branch. You can see here the stent being deployed, and the LED distal was treated with the help of a balloon. So in all, 5 stents were deployed. So we give a long balloon inflation. It looked nice. So this was the final result, which looks pretty good. Absolutely brand new arteries. The patient lived for almost 2.5 years after that. You can see here that in the cranial view, all the vessels look to be reasonably pretty good. So in conclusion, you can see that it's a viable to alternative to CABG in high-risk patients who have been refused CABG for multiple comorbid conditions. And even LMCA bifurcation stenting can be done safely in these high-risk cases with gratifying result. Now, when we looked at the literature, again, the literature is very limited. Procedural success is lower in these longer lesions, 70 to 80% compared to lesions less than 10 millimeter. There's a higher risk of major complications like QA, MI, need for emergency cabbage, death, and slow flow. The restenosis, unfortunately, is high and is in the range of 40 to 55%. So, in general, what are the tips that I would like to leave it for my friends who are watching this talk? Well, first thing is it is possible to treat all these conditions that I have enumerated. Even a artery which has been dissected earlier with a balloon, we have done 2 or 3 cases, ROTA beyond the dissected artery. Uh, so the tips are that it is preferable to use a stepped burr approach in these unusual conditions. Don't go for a larger size burr to start with because you're more likely to end up in slow flow or no reflow phenomena. Avoid rota in cases of significant dissection or significant thrombus load in STEMI, because in such cases you are likely to cause perforation or a slow flow. ROTA should be done in these STEMI cases only after adequate thrombosuction has been done. And then you are satisfied that there is not going to be a slow flow or a no reflow, at least permanent slow flow. Then in that case, the patient may eventually collapse on the table. Keep the ROTA speed to a conventionally less than the conventional speed of 150,000. Be prepared for a slow or a no reflow after ROTA in STEMI, and if required in intractable no flow, do not hesitate to put a IABP because that helps a lot in these cases. In cases of CTO, ensure that ROTA wire is placed in the vessel lumen created by a stiffer wire used for crossing the CTO. Otherwise, do not do a ROTA, because if you do a ROTA in a wire which is passing through the wall of the vessel, you would cause definitely a perforation. So with that, I think I finished my talk, and thank you very much for giving.